This session will start with a talk facilitated by Dr. Shahid Jamil, followed by a talk by Professor Gautam Menon. The talks will be followed by a conversation moderated by Dr. Chitra P. Dr. Shahid Jamil is the Chief Executive Officer of the Wellcome Trust DBT India Alliance. Prior to joining the India Alliance, Dr. Jamil was a group leader of virology at the International Center for Genetic Engineering and Biotechnology. He has published over 120 peer-reviewed papers and served on various review and advisory committees of the Government of India and the World Health Organization. Dr. Jamil received the Shanti Swaroop Bhatnagar Award in Medical Sciences, which is India's highest mid-career research award. He is also a fellow of the Indian National Science Academy, the Indian Academy of Sciences, and the National Academy of Sciences, India. Dr. Jamil, please.
Thank you. You know, with that kind of introduction, you wish your wife was here in the audience, and you know, she would at least know that I'm not a useless person. Anyway, so thank you, Arun, for that lovely talk and telling us everything about the virus. There will be some repetition, maybe some new things, but I hope you do get some new information. Okay, so is this a pandemic yet? So I think it's important to understand the difference between an epidemic and a pandemic. So the definition of an epidemic is rapid spread of infectious disease to a large number of people in a population in a short period of time. This is an epidemic. Example of Ebola. Cases spike up for some time, some weeks, some days, months, and then drop off, and it's in a limited area. This was in Western Africa, right? It didn't move out of there. Can the lights be down a little bit? I don't know how many of you can see this. This is the evolving status of COVID-19. And this is from the Johns Hopkins University Center for Systems Engineering website. And as you can see, the cases are spreading around the world. So is this a pandemic? A pandemic is epidemic of disease that has spread across a large region, for example, multiple continents, is getting there. For example, the outbreak in Africa is really not expanding right now to qualify calling it really a pandemic at this point. And I'm not even sure, Gautam was just telling me that WHO may not even have pandemic as a term anymore. Public health emergency of international concern is something that they have said, and that's pretty much the highest that they can go at this time. Nevertheless, I mean, those terms don't mean very much. So again, to put this into perspective, I have listed out some pandemics here. Plague in the 14th century was a pandemic, went all over. And many of you may not realize that the word quarantine actually comes from the plague. Quarantine refers to that 40 days that ships were not allowed to anchor in port to take care of the incubation phase of Black Death or plague at that time. Look at this, 75 to 200 million deaths. Spanish flu, which all of you have heard of, which started after the First World War, lasted about 2 years, 1918 to 1920. About 50 million deaths across the world. It turned out that at that time, 1/3 of the world's population was infected. Roughly 500 million people were infected by influenza virus at that time. Closer to our memory, swine flu, 2009, 214 countries were affected by swine flu. We are talking about 70 plus countries today being affected by COVID. Again, HIV/AIDS, we have stopped thinking about it as a pandemic. But it is a pandemic and it's continuing. It was identified in the early 80s and it's continuing. There are roughly 38 million people who have been infected, out of which about 30 million have died. That's a pandemic. So this is to put to you in perspective what a pandemic really looks like. And one wishes this one doesn't become one. All right. 75% of emerging viruses in the last 4 decades have come from animals, have a zoonotic source. And this map here shows you all kinds of viruses over the last 4 decades that have jumped from animals into humans, either directly or through an intermediary host. Many are newly emerging, some are re-emerging. Again, the point is, what are we doing about it? What are we doing to limit the transmission from animals to humans? If data shows you that about 75% of newly emerging viruses are coming from animals, we need to be coordinating our effort to see what's there in animals. And that's not happening as much as should be happening. There are various developments that facilitate the spread. I mean, airline travel, global trade, urbanization, the growth of mega cities, all of those things. But then, between SARS and now, Arun showed very nicely how our response has been. If you compare that to the 1918 flu, I mean, for decades, we didn't even know what caused all those deaths, right? And today we have the technology where within a week, the sequence comes out. So those are the advances that will facilitate control of this outbreak or any future outbreak technology. The point is whether the technology is easily available, are technology platforms being shared, is information being shared? Those are going to be the critical issues. Viruses have always been there, viruses will always be there. It is our ability to share data, it's our ability to connect, which is going to limit the destruction that they cause. If we think that we're going to rid ourselves of viruses, that won't happen. All right. So look at the developing situation now. Ebola, case fatality rate of about 40%. 9 countries affected. SARS, 9.5% case fatality rate, 29 countries affected. Swine flu, 763 million people who are estimated to be infected in the swine flu pandemic, which was in 214 countries. Thankfully, the fatality rate was low, but then if that many people are getting affected and you have only a 0.04% fatality rate, you still end up killing about 300,000 people, right? MERS, again, high fatality rate, but the number of high CFR, but the number of deaths was limited, and the spread was limited. Today, the situation with COVID is roughly 93,000 cases, a little over 3,000 deaths, 3.4% case fatality ratio. 78 plus countries have so far reported cases, positive cases. I urge you to look at these 2 graphs. And this is again from the Johns Hopkins site. This is the growth of the cases in China. The green line is the number of people recovered, and the yellow one is the cases at places outside China. A few things become a few things are relevant here. The outbreak in China is leveling off. It is not increasing at the same rate as it was increasing earlier. The number of recovered cases are going up. The rate is going up. The slope is steeper. But the slope is getting steeper also in the outbreak which is happening outside China now. So while China, because of all the measures they put in, quarantine, really locking down on their country, has been able to stabilize this. The number of cases, by the way, are still high in China, but the outbreak seems to be leveling off. But the worry is that the outbreak seems to be expanding, accelerating in other parts of the world. This shows new confirmed cases and recovered cases. What is heartening to see is that the number of recovered cases on a daily basis are almost equal or more than the number of new cases that are appearing on a daily basis. Okay? So again, a lot of it is the China effect, because these numbers are much more than these numbers. I do hope that because since the outbreak is going to accelerate in other parts of the world, the red bars again don't start going taller and taller. Now, the outbreak is expanding to new areas, and here is the latest data. If you look at China, roughly 80,000 out of the 93,000 cases, roughly 80,000 cases are in China. Out of the 3,100 deaths, most of the deaths are in China. And not just in China, but in the Hubei province where Wuhan is located. But look at what's happening in these countries. Iran, Italy, South Korea, Japan, and France. Iran has the case fatality rate almost the same as Hubei province. Italy a little lower maybe. South Korea dramatically lower. So when I look at this from the point of a virologist, these are the questions I have. Are we already seeing the virus adapting to human transmission? Are we seeing different lineages that are seeding localized outbreaks? Or does all of this simply reflect variable healthcare? So for example, can we say that in Korea there is better healthcare than in Iran? Probably yes. But is this effect simply that? We don't know that. I was just checking with Chitra whether the Iran virus has been sequenced or not. It has not been sequenced. The virus in Italy looks very similar to the virus in France, the European cluster of the virus. So this is an evolving situation. If you ask us today which of these is true, I would say I don't know. It's evolving. So let's keep an eye on this and see what's going to happen. Again, Arun showed this mortality by age. I just wanted to again emphasize the point that it's the old and it's people with other comorbidities, other chronic diseases, heart disease, lung disease, kidney disease. These are the people who are succumbing largely to the infection. There's a lot of smoking in China, a lot of compromised lung function in China. So are we seeing all that death? Imagine what happens if something like this gets into the Middle East, where a majority of people smoke. There is underlying lung disease. So that's why I keep saying that I'm more worried about the outbreak in Iran at this point than anywhere else in the world. And I do hope that doesn't expand. Iran is also in a very precarious situation because it is under US sanctions right now. So it can't send its virus to places like CDC or other places to get data. It cannot access data. So that brings in a potentially very, very dangerous situation. And definitely the clerics in Iran are not helping the situation, because there's a big religious holiday coming up, and they're asking people not to worry about this virus. Go and attend this religious congregation. Perfect place to spread the virus. And I do hope that better sense prevails there. Now this is an old map. This was published in 2008 by Kate Jones and colleagues from the Zoological Society of UK. And the thing that I want to show on this is that whether it's zoonotic infections from wildlife, from non-wildlife, drug-resistant infections, or vector-borne infections, all of these show India to be a hot zone. India, if you see, stands out. The question that I pose to myself, the question I pose to policymakers in India is, what have we done over the last 10, 12 years to mitigate this? So look at the situation in India. I really think, since most of the virus outbreaks are coming from animals, One Health becomes an important issue for us. We are simply concentrating on what happens in humans, whereas the source is somewhere else. So this I've already told you, India projected to be a hotspot. Look at the situation here. We are about 1.3 billion people, over 500 million livestock, about 730 million poultry. That amounts to about 400 persons, 156 livestock, or about 220 pieces of poultry every square kilometer in this country. The density of humans, livestock, poultry is one of the highest in the world in this country. And if viruses are going to jump from animals into humans, we need to be watching this out very, very carefully. In the case of this virus, we've seen that bats are a major reservoir for emerging viruses. Sequence comparisons have been done, and it's most likely coming from bats, either through an intermediate host or directly. By the way, there was a study by EcoHealth where they found about 400 different viruses in bats, and some of these viruses could directly be grown in human cells, which means that they don't need any adaptation in an animal to infect humans. So one could directly get infected from bats. And as deforestation is happening, as more and more bats are coming into contact with humans, this increases the possibility. India, by the way, also has 117 different bat species that are indigenous to India, about 100 subspecies, but we have no knowledge of what infects bats in India. There was an attempted study by a group in Bangalore that looked at only immune response in people in Nagaland who make it a point to harvest bats at a given time of the year. There's actually a bat harvesting festival in Nagaland where they go into a cave, put nets, and catch bats. In this tribe, yes, so they eat bats. They eat bats. No, they're not keeping them as pets. Yeah, they eat them. So in this tribal population, they looked at whether there is any cross antibody reactivity between bat serum and human serum. And they did find that, yes, there is. Unfortunately, just like Arun's unit has been shut down by powers to be, even that lab has been told you can't work on this. So that's our level of preparedness that I'm most worried about. The point is that technology to do all this is not complicated. Technology is available. China is able to do this. The world is able to do this. We are also capable of doing it, yet we're not doing it. So there is really this problem of governance and intersectorial problem in India. Animals and humans come under two different ministries in India. Animals come under the Ministry of Agriculture, whereas humans come under the Ministry of Health and Family Welfare. And these two ministries rarely talk to each other. So, that is really the core problem of dealing with One Health in India. So how should we prepare? Well, this has been said earlier. We need to enhance public health. We need to enhance our ability to detect early both symptoms as well as have diagnostic tests available. We should have the ability to treat, quarantine, which means hospitals, which means facilities that can give supportive care, respirators, oxygen, everything that was talked about earlier. Very important to have public trust. And trust in public institutions is critical, but the mixed messaging that is happening in the country today doesn't help us develop that trust. Every Tom, Dick, and Harry is standing up and talking about, this animal product or that animal product is going to, prevent the disease. But there is no clear messaging from the government to say that that is rubbish. You can't just keep quiet. You can't just ignore when somebody else is giving false information. So when WHO says that there is an infodemics, it's not a pandemic, it's an infodemic, it's right, and there's a lot of false information coming out, and that mixed messaging is not helping us. Preparedness also involves research. This is the time to do some research, field research, but the most critical time to do research is between two outbreaks. Unfortunately, we forget about the outbreak after this, it disappears. The world forgets about it. I'm talking about the most developed nation on earth, which is giving 1 billion in emergency relief for COVID, but in the same week, it's cutting its health budget to deny money to CDC and NIH and other places that deal with this. So it's really, really important that we continue to do research. If we had, for example, continued to do research on SARS drugs and SARS vaccines after SARS so-called disappeared, those would be useful today, right? This is very closely related. This uses the same receptor as SARS uses to enter cells. So if, for example, we had a receptor blocking antibody or a small molecule that blocked the receptor, that would have therapeutic value today. Yet we don't have that. So where is this one going? That's a very tricky question to answer, and nobody can really answer that question. I feel that there are three possible scenarios. We will have very large number of cases with global spread, but with low case fatality ratios, somewhere in the range of 0.1 to 0.5. And the virus will become endemic in humans. Other coronaviruses have become endemic. This is going towards becoming endemic. This is not going to go away. The good thing about viruses is that they only kill very early in their adaptation to humans. Once they reach an equilibrium with humans, they don't kill as much. Their fatality goes down. And there's a very simple reason for it. A dead host is completely useless to a virus. If it kills you, you're not going around spreading it, right? And what is the purpose of a virus? The purpose of a virus is to make more virus. Just like our purpose in life is to make more humans. Viruses also make more viruses, right? So this is a possibility. The second possibility, which is a very scary one, is that very large number of cases, but with a continued CFR of 2% or 3%, which is going to lead to very high levels of mortality around the world. This, I think, is becoming more and more remote, that the outbreak will die out in summer because of temperatures and all of that. We fail to realize that the virus is not just lying around somewhere getting exposed to sunlight and heat. It is in us. And we are warm-bodied mammals, right? We maintain our temperature at 37 degrees with a lot of humidity in our nasopharyngeal passages. So this is what the virus likes. Good mix of humidity and moderate temperatures. So we are the carriers. We are the ones that are going to be spreading us. So I don't really think the third possibility is going to happen. The good thing is that over a period of time, herd immunity will develop. Enough number of people will get infected and develop antibodies and get over it. By the way, the number of 90,000 that you're seeing today is only confirmed sick people. This is not the number of infections. The number of infections is likely to be 10 times higher. It's just that we don't have the ability to measure that. We're not doing community surveillance. We don't have a good test to do community surveillance, and that's why. So herd immunity will be there, but then, and also some critical factors for virus spread may be missing in some populations. Those are the positive points. The negative points for sustenance of this is travel and commerce. I mean, in 12 hours, the virus goes from one part of the world to the other, and you can't do anything about it. The way the world is connected, the supply chains are the ones that carry the virus. Not just the virus, any infectious disease. So it's at this point very difficult to say what's going to happen. The last point I want to make is that we need to really make health security a matter of national security. We think of national security only arms and ammunition, securing borders, buying bombs, making bombs. The world has changed. Today we see that investments in public health and preparedness are going to be as critical for national security as anything else. And I will give you an example with relation to supply chains and building local capacity. In 1991, India imported only 0.3% of its pharmaceutical active ingredients from outside India. Today, greater than 85% of our APIs are from outside, mostly from China, right? China is shut down. The API supply is cut. If this situation continues for many more months, we will be in a very critical situation with reference to drugs and pharmaceuticals. India has a very big generic pharma industry, but with price controls on drugs here, generic pharma cannot make its own APIs. Instead, it relies on the huge market in China and at the rate at which they can sell. So even companies like Cipla that used to make their APIs are not making them anymore because it's cheaper for them to import from China than to make them here. So we need to really think about this. I mean, today China is closed because of an outbreak, and we're not getting APIs. What if it decides to hold back APIs? Think about that. So that's why I say invest in research, invest in building local capacity. Unless we do that, we are going to be in big, big trouble, considering the population density, considering the animal density, and considering the very sketchy public health infrastructure in the country. Okay, I don't want to scare you anymore, so I'll tell Gautam to give you some good news. Thank you.
Okay, so I'm Gautam Menon. I work at Ashoka University and the Institute of Mathematical Sciences in Chennai. So before I start, one public service announcement. All of you have heard about the importance of washing your hands, and that's certainly true. That's the best thing that you can do, is to wash your hands regularly using a detergent-based soap. But don't forget about this. This is a device that your hands touch and comes close to your mouth and face. If you wash your hands but don't wipe this device at regular intervals with an alcohol-based swab or something, all of that effort is wasted. That's just sort of background to what I want to tell you about. Much of what I wanted to tell you about has really been covered in the last two very nice lectures. So I'm going to talk about somewhat more general features of thinking about disease. My background is as a mathematical modeler with an interest in diseases. So I model multiple things, but I think of models as being able to provide useful information to people in a way in charting out the course of possible courses of diseases. And I look at models from that point of view. So here's a sort of, again, a quotation that describes pretty much what the last two speakers said, that in our crowded world of 7.8 billion people, a combination of altered human behaviors, environmental changes, and inadequate global public health mechanisms can turn an obscure animal virus into an existential human threat. And that's really the sort of question that we encounter when we think about COVID. So again, you should think of this as a progression of zoonotic viruses that sort of started here from SARS, MERS, and SARS-CoV-2, all of which are similar to each other. These are all coronaviruses. And as Shahid said, this line will keep going on. Wherever there are humans and animals, there will be a transfer of viruses between them. So I want to sort of look back at an analysis that was done recently of a bunch of lessons that we learned from public health, from everything before COVID-2. So that's from the diseases of cholera, Spanish flu, polio, AIDS, SARS, and Ebola. And there are a bunch of lessons that are also applicable here. And the first lesson is that governments are typically unprepared and resistant to taking steps that are necessary to contain diseases, especially in the early phases. We saw this a little bit with the Chinese response, which overall was okay, but there were some questions of a few weeks in between when the cases started coming in early December. Had that been notified earlier, things might have changed a little bit. It's not clear how much they would have actually changed, but it's fairly natural in the scheme of things for governments to try and conceal as much as possible for fear that the news might get out and various bad things might happen. To give government some credit for this, to calibrate your right response is hard. If you do too much, you squander public trust because they think that this has all been for no use at all, and all of this effort and all of this investment that was made had no tangible outcome. If you do too little, people die as a consequence of this cases of fatal disease. And in particular, as Gagandeep Kant pointed out, that public officials are reluctant to publicize infections for fear of economic consequences, fear of other consequences that are more personal to them. That's another thing to worry about, which again is in the context of all of these diseases that have come before us. For diseases like COVID-2 and these other ones, the doctors really have good treatment options. It's really management that's important. And nursing care is often what's needed most in these particular cases. It's really management and nursing that come together. And as Shahid pointed out, with no effective treatments, unscientific remedies will abound. So you will see all sorts of stuff about cow urine being good and this being this and so on, and tulsi being ground up fine, etc. And in the absence of any vaccine that we can provide, which currently there is no vaccine, any medication, any drugs, this is what will happen. And we have to be able to counter this tide of misinformation that we will encounter. Again, these are all points that have been made earlier. I'm just making them again because I think they're important enough to make. If we plan for the last pandemic, but we don't do enough to plan for the next one. And the moment a disease falls off the headlines, the public forgets and preparation falters. And it's very important when you think about diseases in the context, especially of India, to think really long term. And in order to do that, you have to strengthen capacity. And that's fundamental to being able to deal with outbreaks of disease. So this question of is it a pandemic or is it not? So I will come down very strongly on the side that it is a pandemic. We don't need the word to tell us about this. And it's a pandemic because now there is community-based transmission across multiple parts of the world. It's certainly not confined to China anymore. There's a cluster of cases here. The Iran cluster is expanding rapidly. There are cases from between South Korea, Iran, and Italy. That's already a large number of growing cases. And that, I think, is enough. We should not be bogged down in the fact of has the WHO declared a pandemic formally, which currently it may not even be in a position to do, because I think the last pandemic declaration was for 2009 H1N1. So I think the FEAC, the Public Health Emergency of International Concern, is their highest classification of disease. And so rather than wait for an official declaration that may not come, it's better to begin to prepare for this. And currently the 66 has become 70 plus. So the questions that a modeler might be interested in are the following. Will a disease spread? How many people will be infected? And how many should we vaccinate if a vaccine were available? And from a modeling standpoint, from a general public health standpoint, the answers to all of these questions rely on just one number that is calculated. And this is usually the sort of end point of epidemiological calculations for a particular disease. And that's called the basic reproductive ratio. And that has a fairly simple and pictorial interpretation. The idea is that for every sick person in a background of people who are susceptible but not yet infected by the disease, how many subsequent people will be infected? So this assumes that everyone else in the population is susceptible. And obviously this is only useful at the beginning of an outbreak, because then you have one infected person surrounded by susceptible people. But as time goes on, you quarantine people, you encounter more and more people who've been infected and then recovered. These numbers will change. The interpretation of this number will certainly change. So Ebola is a fairly small number, swine flu is 2, measles is 18. Measles is highly communicable. And then the question is, what is the number that is appropriate for COVID-2? Can we decide how fast it will spread based on our knowledge and understanding from models, or what the reproductive ratio is for COVID-2? So right now it's currently believed to be somewhere between 2 and 3. That's certainly not as bad as measles. It's somewhere between swine flu and HIV over here. But there have been a broad range of values that are available now in the literature. They range all the way from 1.5 to 4.5. But 2 to 2.3 is probably a safe bet for now. And we will only know later once all the numbers come in, and we're in a better position to understand what this true number ought to be. The case fatality rate, so we've seen a bunch of numbers. The number that we saw earlier was around 3.4. The number that sort of I've been looking at is around 2%. And look at the way this is defined. This is the number of deaths divided by the number of confirmed cases. The difficulty comes in estimating this, the number of confirmed cases. Yeah? Because it should have been number of deaths divided by number of people who tested positive plus number of people who actually fell ill, but their symptoms were mild enough that they were not tested. So then the question is, how big is this number? How big is the number of people who actually fell ill and had symptoms that were small enough that they thought of this as a cold, they were irritated for a day or 2 days, and then they went back into the community? So how much would this denominator change if we could do this more accurately? And that's really the crucial question here, because that really lies at the rate of how likely is it that an infection will lead to a death, a fatality. And that's really the number that all of us want to know. A number like 2% is large. A number like 0.1%, which is usually seasonal flu case fatality ratio, that's a reasonable number because we've incorporated that into our daily lives. We accept that some fraction of the elderly will fall prey to even to seasonal flu. But this is a largish number. And if the 2 was down by a factor of 10 or by a factor of 20, we're already approaching that sort of flu-like limit. What we know, again, sort of to reiterate what people have said so far, is that more than 80% of the patients have some mild illness, 14% is severe, 5% have critical, and about 2% the virus is actually fatal. You've seen this before too. It varies very much by age, health, and sex. And typically this is a disease that leads to fatalities in the 80 plus, 70 plus age bracket. It depends very strongly on whether you have any pre-existing medical condition, cardiovascular conditions, diabetes, respiratory disease, etc. And there's a slight imbalance between male and female responses to this, likely coming from the fact that males and females have slightly different immune responses in general. So the conclusions from this are that older people are predominantly affected, those with pre-existing conditions, that children and young adults recover. In fact, in the age group of 0 to 9, there have been no cases at all in the data sets that I looked at, and symptoms can be mild. And these are all important facts to keep in mind when one thinks about the epidemiology of COVID-2. So look, this is just a global spread of the disease of SARS, MERS, Ebola, and you can see that already you're covering a larger fraction of the globe, including Australia here with COVID-19, that you were not doing with any of these diseases earlier, but certainly with Ebola. And this is just really a question of nomenclature at this point. Do you call it a pandemic or do you not call it a pandemic? Already with deaths, you've exceeded the combination of SARS and MERS over here in this number, and you vastly exceeded the cases that are associated with both SARS and MERS. The essential sort of public health act can be summarized in just one phrase. You have to break the chain of transmission in some way. And typically the ways to do that is to quarantine sick individuals, test rapidly, track contacts, test them as well, restrict movement, so you allow for less mixing of people. For those who are infected, you provide supportive treatment, and the sort of real pressure is to devise a test that is fast, exactly at the point of use, as well as vaccines and drugs. And we heard from Gagandeep Kang that some progress has been made, surprisingly fast in that. So that's all of this are very positive indications that sort of global health is taking questions like this seriously enough, and places like CEPI are really stepping up their act in terms of being able to get vaccines on the market fast. Many things, you need the infrastructure to deal with many patients. Remember that China had the actual political ability to quarantine large populations. Currently, and even as a few weeks later, we were talking about 60 million people in Chinese cities under lockdown. That's a huge number. This is more than the population of Australia or Canada. And the lockdown has now exceeded a month. So to actually have the political ability to lock down cities of millions and millions of people is something that's almost inconceivable in standard democracies. There are many pluses and minuses to this. And the minus is that such measures can create an antagonistic relationship between citizens and governments. Particularly, they make disease tracking more difficult because people are then incentivized not to report a violation in terms of going out to where they are. And the other very important point is that we are not just ill of COVID-2 alone. We are ill with various other things, and individuals who suffer from other illnesses may be denied proper care. And that's an offshoot of thinking about this. And even in Singapore, which is very rigorous about this, you see violations of leave of absence rules. And even in a context where you know that the penal structures in place are very strong, and that violations of the rules that are applied by the government will be treated very severely. The current understanding from pretty much any modeling exercise that you might think of is that movement restrictions don't work, but very importantly, they help to delay the inevitable. Screening, which we've talked about, also helps to delay the inevitable. So we should not think of screening, movement restrictions, etc., as the magic bullet that will solve any of this. What they will help you is actually delay, and what is very important is to use that delay in a useful way. And this really buys you time to prepare, and this can be crucial if used well. So that I think of as being the real contribution of the Chinese system, or the Chinese lockdown, in the sense that the world had enough time to prepare. They could see this unfolding there. There were very few cases from outside China. They were easily handleable. And that month and a half that we had watching the Chinese situation unfold would potentially have been very useful had enough countries taking it seriously enough at that point. What happens next? So, already, so this is from a few days old, this number has gone up. So my own view, my own personal view, this is a pandemic, even if it's not here right now, and opinions might differ on that. There may be lots of cryptic transmission that we don't know about. We should start behaving as if it will be, and concentrate on issues of mitigation rather than blocking. So there's various scenarios. There's an optimistic, gloomy, and in-between scenario, and this is exactly what Shahid was saying. And I sort of tend to something like an in-between scenario. It's very hard to say which one is actually applicable. The in-between scenarios, again, exactly as you said, this would become just like the 4 other coronaviruses that cause a common cold, or maybe, or the virus that causes seasonal influenza. And the hope is that the fatality rate would be something like 0.1%. Why do I hope this? Because of the numbers that are coming out of South Korea. You can argue that South Korea is doing the best job in the world currently of screening people, of really looking at populations together, testing them, and finding out what fraction of them actually have the disease. That number is now much closer to the 0.1. So if that number is correct, then we might hope for an optimistic scenario like this. So then this would be mild, it would recur seasonally, whether it goes away in the summer or not, we might expect it to come back. But we would essentially treat it like we treat the seasonal flu, which itself causes a fair number of deaths per year all around the world. But we are used to that. It's part of our existence. So how prepared are we? Again, this is a question that has come up earlier, and I'm not sure that I have the answers to this. But certainly this is a nice article that again refers to what Arun said and what Shahid said, that You need non-paranoid governance. And this is crucial, that if you have governments who in the business of being paranoid about things that it really ought to do, the governments who don't understand the need for international collaboration, the governments who don't understand the need for research on viruses, you are in trouble. So that's certainly the most important point that you can take away from this. And I don't understand statements like this. Due to the repeated messaging and awareness being spread by the Indian healthcare sector, people realize that hand washing and adoption of protocol were paramount in tackling the epidemic. I don't see this in any practical view. I mean, maybe the few people I know who sit on my floor in the building I work in know this, but I don't see any of the workers in the building with this. So I think this, sort of statements like this are actually misleading because they suggest that we are actually far further along the line of where we ought to be than we actually are. What should we be doing? Well, better communication, avoid panic, simple measures, training for healthcare staff, again very important. Self-isolation, and you have to tell people how to efficiently self-isolate. Again, as was the crucial point was you want to avoid surges in hospitals because our health system is completely incapable of dealing with an increase in the number of patients by a factor of 10 or 100. But most people don't need that. It's only people who are elderly, critically ill, have additional conditions, who really need to be in a hospital scenario. And as much as possible, we should try to ensure that people who can be treated in the community stay within the community and don't overburden hospital facilities. It's especially important in India because we don't have the resources to deal with this. Medical facilities, treatment of those at risk. Here is something that I think we should be doing a little more about. And that is, again, this question of, even in the most optimistic scenario, we're going to imagine that it's going to spread. All we can do is delay it. One way of delaying it is to prepare the public for social distancing. We're a country of festivals, marriages, Kumbh Melas, etc., where large numbers of people come and get together and congregate in large numbers. So can we discourage that a little bit? Can we say, don't bring elderly parents to sit through the whole evening of a wedding, let them come there and then go away? Not. In what ways can we nudge social behavior in such a way as to promote health in the long term with respect to this particular disease? This is somewhere where really it's sociologists who need to be involved in this discussion, not medical people. People who know the structure of Indian society, what will work, what are the appropriate nudges that will actually work in a particular case. So that's why thinking about disease itself is a very multidisciplinary area, and there are many, many different parts, moving parts that have to come in when you conceptualize how to deal with the disease. Finally, essentials and distribution is all very important. As Shahid pointed out, 70 to 80% of our active pharmaceutical ingredients come from China. All our metformin, as I understand, comes from China. So again, people who suffer from diabetes should be concerned with that. We have to worry about where we will source these. Already there are pictures of empty supermarkets in Australia, the US, etc., etc. This has not happened yet in the country, but it will be because China is such a large hub for supplies to India. We need to worry about this particular issue. Okay, this is just a sort of random quote, which sort of summarizes. I would like to reiterate my message that people really need to be calm yet concerned, and to manage their worries that this is going to be something that's going to kill everybody. It's not. A 2% case fatality rate is significant, and that does mean a lot of people would die if everybody became infected. But the reality is we just don't know how many people are going to be infected. We do know, however, that there's probably going to be more spread of this virus. So it's really just important for people to prepare themselves as best they can, to minimize their own risk to themselves and the family, and to just try to approach this the way that you would a cold or a flu. So that would be my intermediate scenario. I think it's the only realistic scenario at this point in terms of what we can do at this point. That's not to say that we should not be doing a lot more in preparation, but at least let us try and do this in terms of the minimal social distancing that I talked about, in terms of preparing society for what might happen, and in terms of finding out what actually the case fatality ratio really is. Is it a little more like influenza? Is it not? So this is just a sort of quick summary of what I had, and I'll stop with this. Thank you.
Thank you so much, Professor Menon and Dr. Jamil, for these interesting presentations. I would now like to call you both on stage for a conversation with Dr. Chitra, who is going to moderate it.
Hi, so I just have a couple of slides to introduce some things, but I will do that while we are talking so that it's just in context. So my plan is like we'll do 10 minutes of this, and I have some points that I think that we should discuss, but then we'll open it out to all of you to pitch in wherever you think is whatever you would like clarifications on. So I just wanted to sort of like fill in some gaps that I felt were from the presentations of this morning. So we are going to see a lot more of this. So we are talking about coronavirus right now, but I'm sort of going to steer this conversation to generally preparedness and detection of outbreaks, which in this case, China has done pretty well. But if this happened in India, our situation would not be very good as of now. And the reason we need to sort of all know about this is that this is a continuous problem. We are going to see it across the globe, and there are many factors contributing to it. And Shahid mentioned zoonotic spread, and so I'll just talk about that a little bit. So we think that there are viruses and other pathogens that are circulating in wildlife. They're sort of always there. They spill over into domestic populations. They can then infect human beings. We usually detect outbreaks at the peak of an outbreak, when there are lots of human cases, often human deaths. And then this outbreak subsides, and then it can start again with a new pathogen. We live in a connected world, so this is a problem. It starts anywhere, it's going to get everywhere. We have some tools, and the newest of these tools is sequencing, and that's sort of what I use, and I guess that's the reason why I'm here also. This device that we use is actually a handheld device, just to give you a sense of the technology and the fact that this is not very removed from what's possible in most settings in India today. So this is a handheld device. This is actually set up in our lab. This is in the International Space Station. This is in Antarctica. So it's a device for extreme environments. It works in many parts of India. So we have taken it to Uttar Pradesh. We've taken it to Assam. We know it works. There are challenges, but we can do sequencing in these places. So with that, I just want to tell you about, I think that these are the things that we should discuss. What is the next generation of infectious disease network? What will it look like? I'm going to give you two examples. We are going to look at a video from nexttrain.org about virus sequences. There's a lot of sequencing that has been done for this outbreak. And we've got a lot of information about how the virus is moving, how it's changing, and we have that very, very quickly. And there are lots of people who have been doing that work from across the world and sharing that information. So how does that work? We can discuss a little bit more about that. How can India be part of this, and what's stopping us? That's also something I want to discuss. Healthcare workers, the emphasis has been in India that they should not spread disease. We are not preparing them enough. We are not telling them about the risks enough. So the risk communication, as Dr. Gautam Menon mentioned, that has to be a bit different here. We live in a culture of fear, particularly from where we are right now politically. I think we need to worry about this. We are also in a culture where we are doing personality-driven research rather than goal-driven research. So I want to ask both of you more about that and how we can change that, because we need to get from here to here pretty quickly. And there are negative incentives on disease reporting. And Dr. Arun, I would like what you think about that and how we can change that. Like what is the model that we should be looking at? And finally, like I think this is the slide that I'm going to leave here, and we can come back to the others. I think that whenever we are looking at outbreaks, we're looking at the host, and the clinical picture will come from clinicians and hospitals and so on. We're talking about pathogens, but this is going to come from microbiologists, both clinical microbiologists and basic researchers, and not keeping them in the loop, not bringing them together, not preparing them so that they can work together. This is like a huge injustice that we do to our own resources. And we need to have the context. So diseases don't happen in a vacuum or in the lab. They happen with people out in society. So we need field epidemiologists, public health experts, local authorities, and policymakers, and they provide this context. And this has to be embedded in supporting structures. So we have to build a community that's connected to the real world, build the tools and resources to do this, keep the borders of the community porous. We need to have anthropologists and work across institutes and companies to do this, and we have to keep an open mind. So these are the points I thought we could discuss. But I just want to play the next train video once. Like this. So the phylogenies are on top, but the important thing is that you can see that the spread began. So the colors are actually slightly different viruses. That is, as the virus is changing, this is an RNA virus, we know it mutates. So as it's changing, it's going to different places. So this is the question that Dr. Shahid Jamil is asking about. Is the cluster in Italy and Iran different? For Iran, we don't know. No sequences from there yet. But we can see that this cluster is actually, the European cluster is slightly different. And if you want to know how different, you can actually go to this tool here. So this actually, and at every node, we can look at what are the changes. So if you just mouse over that node, it'll tell you what are the changes that happened in the virus that actually made it that different clade. So I think this is really cool, and this is happening in real time. So they're sequencing a virus in Brazil from an imported case from Italy today, and that will be up here either today or tomorrow. So the fact that they can do this fast is pretty cool, and we can get, the technology is there. Everything is there to do this. And this is what is useful, like for people to see and to make decisions on. We need to provide information in this form. So yeah, I think we are ready to start the discussion. So should we go to the presentation?
I just wanted to bring forward a point about how much money it costs to do all this and whether it's really worth it or not. The SARS outbreak is estimated to have cost the world about 40 billion, that's dollars, 40 billion. By the time this one is done, God knows how much it will cost us because travel restrictions, supply chains disrupted, all of that. Maybe 500 billion, maybe less, maybe more, I don't know. Now, how much does it cost with today's technology to sequence the entire virosphere? How many, whatever viruses are there in the environment, how much would it cost to sequence all of them? Take a guess. You're close, about 6 to 7 billion. In one pandemic SARS, the effect was 40 billion. It costs only about 6 to 7 billion to sequence the entire virosphere. Yet we find it not useful to do it. We don't find the money to do it because that money is required at a time when there is no hysteria of an outbreak. And that is really what I was talking about, that the preparedness has to be in the period between the outbreaks. And again, without wishing to scare you, I don't think we have seen enough of viruses yet. With the glaciers melting, with the polar caps melting, God knows what's going to come out of there. So, these outbreaks actually present us with an opportunity to shape up. And if we are going to be doing only firefighting and not, taking out the fire insurance and making our structures fireproof, then we are always going to be fighting bigger and bigger fires. That's my worry.
What do you envision for the next generation of infectious disease networks, and how can India participate in it?
India has to participate openly in it. Open access, open data, open hearts, open minds. We're not doing that. Simply we're not doing that. I mean, Gagandeep Kang mentioned earlier that she went to NIH and asked them whether she can get the virus, and they told her, yes, you can, take it. I don't think she'll be successful with NIV if she tried to get the virus from NIV. That's what I'm talking about. This is, sure, if the virus happens to be from an Indian patient, but it's not an Indian virus. I mean, what's an Indian virus? I don't know. This is circulating all over the world. So, why are we not, if we are not capable of doing the sequencing in a day, why are we not partnering with people who can do it in a day? What's the harm in that? Let's get out of this mode that if this infection happens in India, it's somebody's fault. It's nobody's fault. It's not the doctor or the health minister or this or that who's at fault. Nobody is at fault. This is circulating. So let's cooperate, let's participate. These networks are wonderful. I mean, what people have done in a week's time, 2 weeks' time is phenomenal. I mean, did you ever hear of a vaccine going to trial in 3 months' time, 2 months' time? Never. It only happens in movies. When, an outbreak happens and suddenly, the scientist who's the knight in shining armor comes and, makes a vaccine, and 3 days later the vaccine is all over the world. It doesn't happen in real life. But, 3 months taking the first candidate to trials is phenomenal. For SARS, it took 20 months. So we are moving at a wonderful speed across the world, and in India, we need to participate.
So today, if there was a case that had coronavirus positive, I wouldn't even get my hands on the sample because there is a network that has been set up particularly to do that. And it doesn't matter what someone else's ability to contribute is at this point. It's only that particular network, people involved in it, who have access. And they are the ones who have the legitimate right to do it, irrespective of how overburdened they are. Like at this point, they are overburdened with like thousands of tests. It's not that they can't, it's just that it's too much for any one institution or any one body, and there are others who can at this point help, but there are negative incentives for them, not even like not sharing, but there are actually forces that come into play that prevent you from doing work in the future. And like you're forcing young people to migrate elsewhere, to not work in this field because it's just too complicated to handle all the different kind of paperwork that you need to do. There is less transparency. There are two bodies that are involved in doing this kind of work, and it's very hard to work with both of them. I'm sorry, there were some points you wanted to make. Maybe we can take this offline.
Yeah, just to sort of, it's related. I agree completely. The fact that the data should be available. I just want to point out that it's not just health data of virus sequence. Pretty much getting any data out of government is difficult. And this is all the more galling because it's our tax money that pays for this. It's our responsibility. If you take public money to get information such as this, you owe a duty to the public to make it available so that people can do something about this. This is a lesson that just has not percolated in any sense, that you have a responsibility, a public responsibility to make data available.
Let me just add to what Gautam just said. It's this mindset, this responsibility to share data. Open access of information, open access of published information has become a big issue worldwide. India, public money supports, if you look at the entire R&D expenditure of India, 52% comes from the taxpayer, right? So this is the highest in the world. Most countries are about 20%, 25%, less than 20%. Yet if you look at the number of publications that are open access, it's only 19%, right? So the taxpayer is paying to do that research, but the taxpayer doesn't have access to that research. All funding agencies in India, DBT, DST, CSIR, have an open access mandate, an open access policy. That policy, unfortunately, remains on paper. It is not enforced. So yes, I do agree, Indra, that part of the problem is also individual scientists as far as this is concerned. But if there is a policy, it needs to be enforced. That is completely different from what we are discussing now. What we are discussing is sequence data, which I believe is under some kind of unspoken embargo that the researcher who has that data cannot share it.